Praise be to Allah, the cherisher and sustainer of the worlds. I'm Dr. Ramsha Mushtaq Khan, and today I have the opportunity to present case report, case series, ecological and cross-sectional studies under my kind supervisor, Professor Dr. Sara Afzal. Quote of the day: there is no pillar in the world so soft as a clear conscience. The presentation today will include case reports with details on definition, stages, and example, case series with definition, example, advantages, and pitfalls, ecological studies with definition, example, ecological fallacy, Simpson's paradox, and cross-sectional studies with definition, example, concept of bias, and hypothetical study design of a cross-sectional study. At the end of this presentation, the participants will be able to accurately describe the term epidemiological methods and identify the sequence of an epidemiologic inquiry, understand and classify various research study designs, identify and clearly describe various descriptive studies along with examples, advantages, and pitfalls of each design, understand and apply appropriate study design for a given scenario. Starting with the core concept of basic epidemiological methods. Epidemiological methods are carefully designed research strategies to explore the disease etiology. The methods are used to study disease occurrence in a population who during the course of their lives are exposed to numerous factors and circumstances which might have a role in disease causation. The sequence of an epidemiological inquiry is based on 6 questions. Question number 1 is who is affected? That is the person. How many are affected? That is the frequency. When are they affected? That is the time. Where did the affected persons live? That is the place. How did it happen? That is the cause. And how and what can be done to prevent and control the event in present and in the future, which is the application. This is the classification of research study designs based on the assignment of exposure by the researcher. If there is an exposure, it is an experimental study. If there is no exposure, it is an observational study. Now, if there is a comparison group, it is an analytical study. And if there is no comparison group, it is the descriptive study. Further down in the descriptive studies, it is described as ecological studies, cross-sectional studies, case series, and case reports, which is the topic of today's presentation. The case reports and case series are also called as pre-study designs. The case report is a research study design where an unexpected or novel occurrence is described in a detailed report of findings, clinical course, and prognosis of an individual patient, which might be accompanied by a review of the literature of other reported cases, and it remains one of the cornerstone of progress in the field of medicine. Stages of a case report, the main stages of a research activity when planning and undertaking a case study are defining a case, selecting the case, collecting and analyzing the data, interpreting data, and reporting findings. This is the example of a case report of the first patient management of COVID-19 in Changsha, China. This case describes the symptoms, diagnosis, treatment, and management of a patient cured of COVID-19 infection, which may serve as reference for future cases while further studies are needed. Case series is a research study design which is a collection of cases with the same outcome or findings. The general number of cases reported in a case series range from 20 to 50, but may vary from as few as 5 to as many as more than 100. For example, in early 2016, following increasing numbers of infants born with microcephaly in Zika virus affected areas, CDC published a descriptive case series from Brazil on the possible association between Zika virus infection and microcephaly in fetus. The Brazil Ministry of Health established a task force to investigate the possible association of microcephaly with Zika virus infection during pregnancy, and a registry for incident microcephaly cases has circumference more than equal to 2 standard deviations below the mean for sex and gestational age and birth, and pregnancy outcomes among women suspected to have had Zika virus infection during pregnancy. Among a cohort of 35 infants with microcephaly born during August to October 2015 reported to the registry, The mothers of all 35 had lived in or visited Zika virus affected areas during pregnancy. 25 infants had severe microcephaly, had circumference more than 3 standard deviation below the mean for sex and gestational age. 17 had at least one neurological abnormality, and among 27 infants who had neuroimaging studies, all had abnormalities. Further studies are needed to confirm the association of microcephaly with Zika virus infection during pregnancy and to understand any other adverse pregnancy outcomes associated with Zika virus infection. This Brazilian case series was instrumental in the development of the CDC's guidelines for the evaluation and testing by the healthcare providers of infants whose mothers traveled to or resided in an area with the ongoing Zika virus transmission during their pregnancies. This is the interim guidelines for the evaluation and testing of infants whose mothers traveled to or resided in an area with Zika virus transmission during pregnancy. If the infant had microcephaly or intracranial calcifications detected at birth, then the guidelines suggest conduction of thorough physical examination and performance of Zika virus testing in the infant. If it is positive or inconclusive test for Zika virus infection, then the performance of additional clinical evaluation report of the case and assessment of possible long-term sequelae. The advantages of case reports and case series are that they are the key hypothesis generating tools. They are simple, inexpensive, and easy to conduct in the course of busy clinical settings. They provide a comprehensive and detailed description of the cases under observation and allows other physicians to identify and potentially report similar cases from their practice, especially when they share geographic or specific clinical characteristics. There is a lack of comparison group, which is a major disadvantage. The external validity, which is the generalizability, is limited given the biased selection of cases that all are identified in the clinical practice, which we call as the Bergsonian bias. Any association observed in a case report or a case series is prone to potentially unlayered confounding, which is not known to the investigators. Now, the preliminary study designs. Ecological studies is a group of study of group characteristics that are used to understand and the relationship between outcome and exposure at a population level, where population represents a group of individuals with a shared characteristics such as geography, ethnicity, socioeconomic status, or employment. Also known as ecological surveys or correlational studies, and are generally based on secondary data for 2 or more variables from different sources to determine an association between these variables. For example, a study to demonstrate the relationship of the socioeconomic and racial characteristics of a neighborhood and the receipt of angiography in a community-based sample who had a myocardial infarction. Among the 9,900 people with myocardial infarction participating in the atherosclerosis risk in community study, compared to whites from high neighborhood level income areas, blacks from low and medium neighborhood level income areas, as well as white from low neighborhood level income areas, were less likely to be subjected to an angiographic examination. On the other hand, blacks from high neighborhood level income areas and whites from medium neighborhood level income areas were not disadvantaged with respect to receiving angiography. Thus, further studies addressing both individual risk factors and ecologic risk factors, such as neighborhood characteristics and the possible interactions of both type of factors, may improve our understanding of access to an angiographic examination. Now, a very important concept is ecologic fallacy, which is the attribution of members of a group some characteristic that they in fact do not possess as individuals. This problem arises in an ecologic study because data are only available for groups, and exposure and outcome data for each individual in the population is not available. For example, a study in the Northern California exploring a possible relation between prenatal exposure to influenza during an influenza outbreak and the later development of acute lymphocytic leukemia in a child. This table shows the average annual crude incidence rates and relative risks of acute lymphocytic leukemia by cohort and trimester of flu exposure for children younger than 5 years. The incidence rates per 100,000 for no flu exposure is 3.19. For first trimester, it is 10.32. Second trimester, 8.21, and third trimester, 2.99. And the relative risk for no flu exposure is 1.0. For first trimester, it is 3.2. For second trimester, 2.6. And for third trimester, it is 0.9. The table shows incidence data for children who were not in utero during a flu outbreak and for children who were in utero in the first, second, or third trimester of the pregnancy during the outbreak. Below these figures, the data are presented as relative risk, with the risk being set at 1.0 for those who were not in utero during the outbreak. The data indicates a high relative risk for leukemia in children who were in utero during the flu outbreak in the first trimester. Now, the problem is that the observed association is between pregnancy during an influenza epidemic and subsequent leukemia in the offspring of that pregnancy. It is not known if the mothers of any of these children actually had influenza during their pregnancy. What is missing is the individual data on exposure, which is the influenza infection. And the likely reason is that the investigators use birth certificates and data from a cancer registry, both of which types of data are relatively easy to obtain. And this approach did not require follow-up of the children and direct contact with individual subjects. Another very important concept is the Simpson's paradox. It is the phenomena in ecological epidemiological studies in which a trend appears in several groups of data, but disappears or even reverses when the groups are combined. And it implies that inferences hold true for different groups individually, but hold completely untrue when it comes to the behavior of two groups together. It has been claimed that because epidemiologists generally show tabulated data and refer to characteristics of groups, the data in all epidemiological studies are grouped data, which is not true. In cross-sectional case control cohort studies and randomized trials, data on exposure and disease outcome are available for every individual in the study, even though these data are commonly grouped in tables and figures. A very important advantage of ecological studies is that it is the only study in which the group data is available, such as, for example, country by country data on average salt consumption and average systolic blood pressure. Ecologic correlations may provide a more valid answer with regard to the presence of an association than studies based on individuals. It can suggest avenues of research that may be promising in casting light on ecological relationships, but in and on themselves, however, they do not demonstrate conclusively if a true association exists. Cross-sectional study is a type of observational research design that analyzes data of variables collected at one given point in time across a sample population or a predefined subset. It is also known as cross-sectional analysis, transfer study, or a prevalence study. For example, to establish a possible relationship between increased serum cholesterol level, the exposure to electrocardiographic evidence of coronary heart disease, which is the disease. A population is surveyed, and for each participant, the serum cholesterol level is determined, and an ECG for an evidence of coronary heart disease is performed. The presence of coronary heart disease defines a prevalent case. As you can see, both exposure and disease outcome are determined simultaneously for each study participant, as if a snapshot of the population at a certain point in time is being viewed. In a cross-sectional study, data is being collected at one point in time. Another way to describe a cross-sectional study is to imagine that we have sliced through the population, capturing levels of cholesterol and evidence of coronary heart disease at the same time. In this type of approach, the cases of disease that we identify are prevalent cases of the disease in question, which is the reason why a cross-sectional study is also called a prevalence study, because we know that they existed at the time of the study, but we do not know that their duration, the interval between the onset of the disease and the time of the study, or whether the exposure happened before the outcome or after it. Concept of bias. First is the temporal bias, which is the impossibility of determining a temporal sequence of exposure and disease when it is the disease that causes the exposure. For example, prevalent cases of coronary heart disease may engage in leisure physical activity more often than normal subjects, as the occurrence of an acute episode of coronary heart disease may prompt physicians to recommend physical exercise to coronary heart disease patients, a phenomena that is also known as reverse causality. The bias is controlled by obtaining information on exposure by a questionnaire. Second is the survival or selection bias, which is also known as prevalence incidence bias. It occurs when the exposure is related to the duration of the disease. For example, if the exposure-induced incident cases have shorter survival than the unexposed incident cases, prevalent cases, which are by definition survivors, may have a lower proportion of past exposure than those that would have been observed if incident cases had been included in the study. In other words, identifying only prevalent cases would exclude those who died sooner after the disease developed but before the study was carried out. It is the hypothetical design of a cross-sectional study. Cross-sectional studies look at the present only. There is no follow-up period nor an assessment of the subject's history. From the target population, a sample of population without the outcome is obtained, and it is divided into groups of exposed and unexposed. In the exposed group, it is further divided into one which develops outcome and one with no outcome. Similarly, in the unexposed group, it is further divided into one which develops outcome and one with no outcome, so that the risk of outcome in exposed group versus the risk of outcome in unexposed group can be compared. As seen in the 2x2 table, in the top portion, there will be A persons who have been exposed and have the disease, B persons who have been exposed but do not have the disease, C persons who have the disease but not have been exposed, and D persons who have neither been exposed and nor have the disease. Now, we can, based on the we can calculate the prevalence of disease in exposed persons compared to the prevalence of disease in the unexposed person, like A with A over A plus B versus C over C plus D. And also we can calculate the prevalence of exposure in persons with disease compared to the prevalence of exposure in persons without disease, which is A over A plus C versus B over B plus D. The cross-sectional data can help validate and correct errors in measurements such as self-reported weight and height. This comparison allows to estimate a correction factor which can then be applied to the prevalence of the disease and exposure. Comparing the cross-sectional and longitudinal studies. Cross-sectional studies compares different groups at the same time, whereas in longitudinal studies, same group is compared over a period of time. Summarizing the study designs, based on the strength of evidence, the hierarchy of epidemiological study designs is presented. Case report lies at the lowest level of, with the lowest strength of evidence, with then case series, then cross-sectional, correlational studies, and then the cross-sectional studies. Recent updates. This is the case report of Cryptococcus neoformans presenting as a lung mass in an uncompromised patient with a background of pulmonary cryptococcosis as an uncommon infection mainly affecting immunocompromised individuals. The case reports presents that the presentation of cryptococcal disease ranges from asymptomatic pulmonary colonization to severe pneumonia, and it can progress to acute respiratory failure and life-threatening meningoencephalitis. This case report concludes that prompt diagnosis and effective treatment of the cryptococcal disease can decrease morbidity and mortality. Diagnosis requires CT-guided lung biopsy with culture-growing mucoid colonies of Cryptococcus neoformans. Antifungal therapy with intravenous liposomal amphotericin B plus flucytosine is the mainstay of treatment, and clinicians should be aware of the various presentations of cryptococcosis, especially in immunocompromised patients. This is COVID-19 associated symmetrical peripheral gangrene, which is a case series. In this case series, they have discussed the clinical presentation, laboratory parameters, and outcomes in a series of 2 patients of symmetrical peripheral gangrene associated with COVID-19, and also compared those findings. And it concludes that this is to draw attention of physicians to this unique clinical entity of symmetrical peripheral gangrene that often remains unrecognized, leading to delayed etiological evaluation and ultimately high mortality. The self-controlled case series an alternative method to the standard epidemiological study designs. There are several situations where standard epidemiological study designs fall short. So there is a concept of the self-control case series method, which is designed for individuals, which is designed for which individuals act as their own control. For example, comparisons are made within individuals, hence only individuals who have experienced an event are included and all-time invariant confounding is eliminated. The temporal association between a transient exposure and an event is estimated. This paper demonstrates how the self-control case series method provides an alternative to standard epidemiological study designs when investigation association between a transient exposure and an outcome event. Major strength of the self-control case series is that it is self-controlled and accounts for any factor or characteristic that remains constant over the observation period. Where uncertainty over the control of fixed confounders exists in a cohort or case control study, self-control case series may provide a superior design given careful thought is made to applying the methodology correctly. This is an abstract from self-control case series and self-control risk interval study, which are the types of study designs where cases act as their controls, and it is commonly used by pharmacovigilance to study rare events. Currently, there is no existing tool for the assessment of the methodological quality of such studies. This paper presents a proposal of an instrument that has been updated from an already existing tool used for the cohort studies, and it combines the elements of this tool and the premises of the self-controlled case series and self-controlled risk interval studies. Multiple choice questions. Research, question number 1, research identifying the practice of shisha smoking in young adults of a city ABC tends to show a number of individuals n is equal to 100 presenting with heart disease. The study design most effective in generating a viable hypothesis for an association between exposure and outcome would be A, case series, B, correlational study, C, cross-sectional study, D, case control study, and E, prospective cohort study.
C.
C.
No, the answer is A. As I've told in my presentation that case series can have as many as 100 cases. In 1973, the University of California, Berkeley was sued because their graduate school admission figures showed obvious gender bias against women as shown below. One of the explanations for the result probably is A, confounding, B, selection bias, C, systematic error, D, ecological fallacy, and E, Simpson's paradox. The table shows 8,442 men applicants and admitted percentage is 44, and 4,321 applicants, women applicants with admission percentage of 35%, and department wise is presented. So the answer is Simpson's paradox. As you can see in the table below that every department A, B, C, D, E, and F, the percentage of women admitted is 82% in department A, 68% in department B, 34% in department C, as compared to 62% in men in department A, 63% in B, and 37% in C. The findings from a review study highlight the unacceptably high global prevalence of syphilis among homosexuals. And investigator wishes to determine whether the prevalence of the disease is higher among men or women. The most appropriate study design would be A, ecological study, B, cross-sectional study, C, case control study, D, prospective cohort study, and E, randomized controlled trial.
B.
Yes, the answer is B. A recent study suggests that in countries where on average people consume more fat have higher rates of CA breast, Therefore, consuming more fat leads to a higher risk of CA breast. The inference might be the result of one of the following: A. Simpson's paradox, B. Selection bias, C. Confounding, C. Ecological fallacy, and E. Systematic error. So the answer is D, ecologic fallacy. As I have told, the concept of ecologic fallacy, that a large number of group, when the results are generalized, then there is one inference. When individual people and individual cases are studied, then the generalized inference cannot be generalized. In a study designed to examine relationships between diet, lifestyle, heart disease, and stroke, the researchers found that the mean entry-level blood pressures and stroke mortality rates were inversely correlated for certain cohorts with a 5-year follow-up. This finding, termed as ecologic fallacy, refers to A. Assessing exposure in large groups rather than many small groups, B. Assessing outcomes in large groups rather than many small groups, C. Ascribing the characteristics of a group to every individual in that group, B. Examining correlations of exposure and outcomes rather than the time trends, and E. Failure to examine temporal relationships between exposure and outcomes. So the answer is C. I have just told in the previous question that ecologic fallacy is ascribing the characteristics of a group to every individual in that group. Now, question number 6, a researcher believes that the country level rate of hospitalization for cardiovascular disease will increase with increasing levels of outdoor air pollution. The most appropriate study designed to serve the purpose would be A. Ecological study, B. Cross-sectional study, C. Case control study, D. Prospective cohort study, and E. Randomized control trial. So the answer is A. It is the ecological study because the whole country level rate of hospitalization is concerned. Egypt has the highest endemic worldwide prevalence of schistosomiasis, for which mass treatment with parenteral anti-schistosomial therapy was done with reusable glass syringes since the 1920s. A recent study found that the age-adjusted prevalence of the antibodies to HCV is 22%. The study design used most likely in this scenario is A. Ecological study, B. Cross-sectional study, C. Case control study, D. Prospective cohort study, and E. Randomized control trial. So the answer is A, because the whole population is concerned. Smoking causes emphysema. Also, it is found that the survival of patients with smoking-induced emphysema is worse than that of patients whose emphysema results from other causes. As a result, past smoking will be observed less frequently in old than in new cases of emphysema. The bias in this observation can be identified as A. Confounding, B. Selection bias, C. Systematic error, D. Ecological fallacy, and E. Simpson's paradox.
B.
Yes, the answer is B. Residents of 3 villages with 3 different types of water supply participated in a survey to identify cholera carriers. Virtually everyone present at the time underwent examination, and the proportion of residents in each village who were carriers were computed and compared. The appropriate design for this study would be A. Cross-sectional study, B. Case control study, C. Prospective cohort study, D. Retrospective cohort study, and E. Experimental study.
A. Cross-sectional study.
Yes, the answer is A. After receiving radiation treatment for 7 days, cancer patients suffer from both nausea and magnesium deficiency. A researcher wants to pursue this observation from a cancer hospital for research. The study design unable to demonstrate temporal association in this case would be A. Case series, B. Cross-sectional study, C. Case control study, D. Prospective cohort study, and E. Randomized control trial.
RCT.
No, the answer is B, cross-sectional study. As I have told that 2 biases are involved in cross-sectional study. Number 1 is temporal bias and number 2 is selection bias. This is the key of my presentation, my MCQs, and thank you very much.